Welcome to the afternoon session. This session is dedicated to trauma. So may I request Sudhir sir to please come on dais. And as session is running late, so without wasting time, uh, I would like to request Sudhir sir to start presentation. Sudhir sir is currently heading GMC Betia, and sir has vast experience in general ophthalmology and especially in oculoplastic cases. Sir will share his experience in cases of lid laceration, how to manage it. And this session is based mainly on general ophthalmologist, when to treat at their level and when to refer. Thank you, sir.
थैंक यू अमित. खाने के टाइम में पढ़ाई करना अच्छा विद्यार्थी का पहचान है. Basically we all are aware that this era of this modern era is basically now accident has become epidemic, and this does not occur only at workplace. This also occur at your household place also. You can see in many type of injuries, including the eye injuries are many a time not isolated. They are associated with uh, head injury also in a road traffic accident or in mechanical injury accidents. So one should not think that eye injury is alone. So you will have to evaluate the patient in toto, whether the patient is conscious or not, whether the patient is cooperative or any other systemic problem with them is not. So before you examine the eye properly, you must evaluate the whole uh, patient as a whole, so that you have better knowledge about the uh, prognosis and way of management. So this should be taken as a whole, and associated or suspected structural damage must be explored. Most common injury in a lead injury is associated mostly with injury of the orbit as well as face and the globe itself. So uh, you have to be aware that this might be harboring globe injury. So whenever, never try to open it forcibly. If it is not possible to examine the eye globe normally, then examine the eye globe under anesthesia only. And since we know that all facial injuries bears a cosmetic uh, problem with this, and it has a medical legal implications. All facial injuries with permanent disfigurement constitute to grievous injuries. So this should be recorded photographically as well as in a written form diagrammatically. And at the same time, you must at least do so one either of CT scan or ultrasound or X-ray to find out whether there is any fracture or foreign body lying it or not. So after that, you take primary care. So this, if you find that there is only lead injury, this can be taken up uh, separately, and dirty wounds are taken after cleaning and disinfecting. Even injury with animal bite is supposed to be a dirty wound, apart from injuries which have foreign bodies in itself. And so the vaccination status should be taken for. And if the patient is if you suspect that rabies may be there, so vaccination should be taken care for. And if it is beyond your scope for management of lead injury, always do a referral, and but before doing referral, the wound should be cleaned and debrided, and primary stitches can be applied for positions. Means where you will find that the lid tissue is not in position, it has gone somewhere else, so you will have to explore the lid area and make the logical appositions of the skin and lid. And antiseptic dressing and vaccination should be done, especially for tetanus also. And preventive antibiotics should be started. Drying of the wound margins should be avoided. And when more skill is needed, like flap rotation and cutler beard, this should be, you can send to some more experienced surgeon. Success of eyelid repair depends on proper placement and satisfactory suture tension. Lid margin repair is very important to prevent exposure keratitis and maintain the tear film, normal tear film. And post-operative notching of the margin should be avoided because it will cause exposure as well as corneal ulceration, etc. And if you find that the edges of the wound is ragged, then you will have to freshen them so that apposition is good and in which can be taken for primary healing. And pentagonal defect is created when tarsal plate is ragged, because tarsal plate in principle it has to be parallel to each other while suturing each other to the suturing of the lids. Otherwise, there will be notching, and this should be stabilized by external stay sutures like frost stitches at the end of the surgery. And superficial lacerations are very easy. Anyone can do it, and smallest calibers suture should be used, and needle should be cutting needle. It could be either vicryl type of things or natural, even thread can be used, or silk. And final wound edges should be slightly everted. For deep laceration, you must think that it might be harboring some foreign body, and there might be injury to the septum, and there might be injury to the LPS also. And injury to the septum and LPS should be repaired separately, and this should not included into the while suturing the eyelid repair. Otherwise, this could lead to leg ophthalmos. So this should be extra precautions should be taken care of. If you find some fat, it means there is septal injury. And after this surgery, if there is ptosis, that is we call it secondary ptosis, don't try to repair this at the same time. You can take, it can be taken after say 9 to 12 months after that. And the basics of injury repair can be seen here. You see that there is a ragged margin, it has been freshened up, and first lid suture in the center is given with a stronger suture material like 6-0, and after and the lateral 2 are given by 8-0 of vicryl type of things, and then the first it is apposed and tightened in such a way that there is some eversion of the margin, and then this is repaired in 2 layers, that is inner tarsal layer and then skin layer. And like this you can use. This is not a very difficult thing, but you must care that the tarsal plates are parallel to each other after, so that this is called pentagonal structure. And then after repairing this, a stay suture to the opposite side, that is we call it frost suture, is given for better healing. And since it's very difficult to show it in pictures during the operation, so but the basic principle was this. And when there is tissue loss, you need to create tissue. Lid is very elastic, so around 25 to 30% of case loss can easily be managed with direct closure, especially in older age group. But when there is some shortage of the tissue, the simple method of cantholysis with direct closure can be used, and if it is more, you can use Tengel or Cutler beard. So here this is the basics of cantholysis. You remove the skin here and then expose the canthus. The incision is given here, and then this is cut inferiorly, and some type of relaxing skin's undermining of the skin tissue is done so that it becomes mobilized, and this can be stitched like this, and then canthal repair can be done. For larger tissue loss, we can go for cantholysis as well as Stengel, and this can be achieved good deposition for when slightly 60 to 70% loss is there. Similarly, for when the upper lid is lost, when the still the tarsal plate, some part of tarsal plate is there, you can use this rotation flap from lower side, and this can be fixed, and this can be managed easily, and again new canthus is new canthus is made here. Upper lid defects with tarsal plate missing can also be taken by Tengel flap as well as Cutler beard. Here you make a this bucket type of handle in the lower lid, and tissue is mobilized from lower side to upper side behind the lower lid tarsal plate, and then it is stitched in the upper lid, and after 1 month or more you can cut it from here and remove the suture and then stitch this lower lid here. This will give a good cosmetic look as well as need for good normal lid. Since it is upper lid, so you may not have a need many a time tarsal plate again here, but if you think that there is chance of floppy upper lid, you can always take a cartilage from auricle or nasal septum and place in between this. People are placing some type of plastic or buckle type of thing for this, making this artificial tarsal plate also. And at the same time, if you find some canalicular injury and you don't have
sir, canalicular injury will be.
I am not imposing. आपके लिए रास्ता बना रहे हैं. So before referring to Dr. Ravi Ranjan, just he will find something difficult while finding out canaliculi. So you thread 20 catgut or vicryl in the canalicular end, and then just thread and give a stay suture, and then we'll write a good letter to Dr. Ravi Ranjan to make it better. And with this, I say thank you.
For excellent presentation, sir has beautifully explained all the methods, and especially for PG when they are in emergency and they suture these lacerations. So following all these criteria for especially lid margin suturing is very important, and how defect has been created and it should be sutured. With this, now I request Ravi Ranjan sir for his presentation. Sir is director of Awadh Eye Care, Bikramganj, and sir is lacrimal guru of Bihar. Any lacrimal talk is not complete without sir. So sir will be speaking on repair of canaliculi.
Good afternoon, everyone. Thank you, Amit. My topic for today is management of canalicular laceration. These are the anatomy. I want to skip this because of lack of time. Canalicular injuries are common in. अब इसमें हम क्या करें सर? आगे ठीक. Canalicular injuries are common in medial eyelid trauma, that is 16 to 36%. Most injuries occur in young adults. 83% of them more than 30 years, and involve lower canaliculus in roughly 66%, upper in 27%, and bicanalicular in 63%, 6.3%. And based on the mechanism of injury, canalicular laceration are classified into direct, indirect, and diffuse injuries. And the direct type occur mostly with sharp objects, indirect due to blunt tangential force or blows, and the diffuse injury refers to extensive lead trauma associated with orbital fractures, glove rupture, and other body injuries. The primary repair of the end is must, because there is a very good outcome. Repair should be done within 48 hours. Successful repair have been reported within 5 days of the injury. And why to repair monocanalicular laceration? Because 25% have symptomatic epiphora, when an isolated inferior canalicular laceration is not repaired, and the upper canaliculus drain 20 to 30% of the tear when the lacrimal pump is functioning normally. Etiology of the canalicular lacerations are many, and in our part, uh, most of the cases I have seen blouse hook fastener in children, and others are in young, more than 30 years in young adults. And technique of now we come to the technique of repair of canalicular injury. They are making direct catheterization or retrograde catheterization. Direct catheterization we can do with bicanalicular stent, monocanalicular stent, that is mini monoca, or a stenting material may be IV cannula. And retrograde catheterization we do the pigtail probe, and this is was described pigtail probe for retrograde intubation. And this is pigtail probe, usually in case of monocanalicular tear. And disadvantage of this pigtail probe is damage to the common or uninjured canaliculus, and the risk of creating a false passage is there. And the material for canalicular stent are nylon, maybe nylon, polyethylene, supramate, Teflon or silicone. And advantage of silicone material is they are inert and stable. Soft, pliable silicone minimizes ocular irritation and tissue trauma, and prevent stricture after repair and maintains proper alignment. And the canalicular stent may be mini monocar or odonotube, and a bicanalicular odonotube silicone tube attached with metal rod at either end, or pass through both canaliculi, retrieve beneath the inferior turbinates using this hook. Most commonly used in and the mini monoca stent is first developed by Dr. Fayed from France. I am just in there. It is self-retaining circular perforated collars at one end connected to the bulb via a small hollow tube. And the advantage of mini monoca stent over bicanalicular stent is that monocanalicular stent avoid manipulation of normal canaliculus. Self-retaining nature, so no need to suture, non-irritant collarettes, and the less traumatic passage and relatively more rigid nature, and intranasal manipulation is not required with mini monoca stent. The outcome of a mini monoca is stent has widely been used in repair of monocanalicular laceration, and Milind Naik in Italy reported premature stent extrusion in 11% in patient managed for canalicular laceration, but still the use of mini monoca monocanalicular stent for monocanalicular injuries as well as bicanalicular injury achieves anatomical success rate in 90% of the patients and functional success in 100% of the patients. And now we come to my study, and the 12 patients with canalicular tear who were repaired with mini monoca stent were reviewed, and out of total 12 cases, 8 had isolated lower canalicular tear, 1 had isolated upper canalicular tear, and 3 cases had both upper and lower canalicular involvement. We lack time, that's why many of the cases I am escaping. This is case 1. It is 35-year-old male, right lower canalicular tear and assault by a fist and repaired by mini monoca stent. And this is the picture of POD5, and below is picture POD3, 3 months. And the case 2 is 3-year-old child, right lower canalicular tear, trauma by metal bangles and repaired with mini monoca tube. And upper one is POD day 5, middle one is 3 months, and third one is after 3 months. And case 3 is a 9-year-old child left binocular tear, history of fall from bicycle, and repaired with 2 mini monocas, stent on the same day. And this is a video. Thanks to Amit for this video.
वीडियो
नज़र ही आ रहा सर, बहुत एक्सप्लेन करने से ध्यान भटता है. The same procedure with upper ear canaliculi. It is engaged with minimum of yeah. Yeah, and this is a picture of POD 1. Middle one is POD 1 month, and at the 6 months. And the conclusion is one should assume the canaliculus has been cut if there is any injury extending close to the lid margin, medial to the puncta of the eyelids. And canalicular injury, if repaired within 48 hours, leads to higher success anatomical as well as functional. And thank you. Thanks for patience listening.
Thank you, sir, for excellent presentation. With the advent of silicone stent, especially self-retaining stent, these injuries are basically better repaired and cosmetically very good. That is very important. So with this, thank you, sir. Now I invite Dr. Prabhakar for his presentation on management of corneal perforation. Dr. Prabhakar is currently associate professor in AIMS Kalyani and is very accomplished surgeon of cornea, ocular surface.
Thank you, sir. So I will be talking on management of corneal perforation. The learning objectives of my presentation would be first to know what exactly is the aim of surgery, what are the keratorefractive principles involved, the basics of suturing. We will have a video demonstration, and we will also talk about things we often miss, though many of these things have been covered by Sudhir sir as well. And at the end, we will summarize. So let's start with the aim of surgery. So whenever we are encountering a case of open globe injury, and what is the primary aim of surgery? The primary aim of surgery is to attain a complete watertight closure. Removal of the disrupted lens matter into the anterior chamber and visual rehabilitation are secondary and tertiary aim. The primary aim always is just a complete watertight closure. That's it. Now let us understand the various keratorefractive principles and the effects of suture and laceration on the keratorefractive aspect of cornea. We all know that human cornea is said to be a prolate cornea. Now these prolate cornea means that the central part of the cornea is steeper and the peripheral part of the cornea is flatter. So how does the corneal tear affect this? So a corneal tear, as you can see in the schematic diagram on the left side, on the right side, that corneal tear, when it opens up as a valve, it causes significant flattening of the cornea. In the picture here, this picture, you can see that the tear margin or the laceration margin has, the incision is flattened along the, I'm sorry, axis perpendicular to the incision is flattened. However, the axis which is parallel to the incision is steepened. This is very similar to that of cataract surgery that we perform, wherein we sit on a steeper axis, we intentionally give an incision, and we know that we have sat there just to decrease the steepness of that particular axis. As far as effect of suture to the keratorefractive aspect of cornea is concerned, so if at all we have placed a suture here, what exactly it does, it brings the two limbus closure. That means it causes steepening of this particular axis, and simultaneously because of the coupling effect, it causes the flattening of the perpendicular axis. Now let's learn about the suturing nuances. The very important armamentarium that we have in this aspect would be the needle holder and the suture material and the needle. So always hold the needle with the tip of the needle holder, and it should be held at lateral 1/3 and medial 2/3 junction, because this helps in better maneuvering of the during the surgery. How should the needle be placed? The needle should always be placed perpendicular to the surface of the ocular surface. If at all we are not able to attain that because of the flattened surface, we can lift the margin. However, this is not true for the corneal tear. In corneal tear, there should be absolutely no touch technique at the tear margin, because this being very much edematous, it is very much friable. So we might lose corneal tissue in that area. So it's a no touch technique. Rather hold at the limbus, rotate the globe as per your requirement and pass the suture. As far as zone of compression is considered, so for any incision or any tear to close, there should be n number of sutures should be placed. Now these suture, how does it close? We place sutures. If there are longer suture bites, then it will have a longer zone of compression. And for a tight wound, one should have a overlapping zone of compression. This can be attained. However, if there is no overlap of the zone of compression, as we can see here at the side B, there will be significant leak and the chamber may not be formed. So always remember, if we have taken a larger suture bites, it will be having a larger zone of compression, so the distance between two sutures will also be more. However, if the suture bites are smaller, the zone of compression will be smaller. So to attain the overlap of the zone of compression, we will have to place sutures closer. So now let's see, if a patient comes with a corneoscleral tear, how do we go about it? The first thing is alignment, anatomical alignment. First thing is to secure it at the limbus, so that there is no overlap or override of sclera over the cornea, or vice versa. So the second thing is secure the angles, and subsequently rest of the corneal part is sutured, and then the scleral part is sutured. If it is an isolated corneal tear, secure the angles first and then rest of the sutures. Always remember to place perpendicular sutures to the tear margin, otherwise there will be a tissue talk, wound slippage, wound gap and leakage. As far as the length of the suture is considered, the suture bite should be equal on both the sides in terms of the posterior surface of cornea rather than the anterior. So as you can see, the D option here, the tear margin is bevel, but the suture that has been passed is equal on both the sides in terms of the posterior part of the cornea. Yes, as far as the depth is concerned, it should be 90% depth. Anything less will cause wound dehisce, is likely to weaken the wound. Anything more than that, that is full thickness, can cause tract infection, can cause leakage, and can also cause epithelial ingrowth. Tying the knot is just 3-1-1, that usually we follow for all cases. Now, knowing all these nuances as to how to suture, here we can see if a patient presents with a large tear like this, put peripheral tighter and longer sutures to attain the same configuration, the prolate configuration of the cornea in the peripheral part. So as the sutures are tighter and longer, it will be wide apart placed. However, when we approach to the center, it should be smaller and closely placed. So the goal of initial assessment is to recognize any emergent condition, which sir has already talked about, so I'm not going into the details. Just remember, when a patient comes to you, get these investigations done, admit the patient, put an eye shield, do not instill any topical eye drops, give injection tetanus toxoid, counsel the patient that this is just a primary surgery for closure and the patient might need subsequent surgeries. You can also talk about the risks associated, like endophthalmitis, and if the injury is severe, you might need to go for enucleation, so you should take the consent as well. So surgery should preferably be done under general anesthesia, if the tear is very small, one can go for peribulbar, but don't go for ocular massage. So here is a small video which I would like to show. If there is a corneoscleral tear, always try to look for first flush the ocular surface with saline. Try to look for the extent of tear, posterior extent of tear. So do a localized peritomy. So once the localized peritomy is done, you can see the posterior extent of tear. Abscise the uveal tissue that is prolapsed, form the anterior chamber, and usually you should make the side ports away from the tear margin. Once the anterior chamber is well formed, secure the wound at the limbus so that ocular alignment can be done, and subsequently place further sutures. Post-operatively, you can give systemic analgesic, broad-spectrum antibiotics, topical antibiotics, cycloplegic and steroids, and subsequently the patient can be followed up later on. So the complications you can encounter are the retained intraocular foreign bodies, keratitis, secondary glaucoma. So the take-home message, like anyone who is just starting the residency and is in the OR and is encountering a case of ocular trauma, remember you can also perform a tear repair. Just remember that you should first align you should consider anatomical alignment first, secure the angles of the tear. Suture bite should be equal on either sides of the posterior tear margin, and suture bite should be perpendicular to the tear margin, and suture depth should be 90%. If you follow all these rules, anyone can repair any type of corneal tear. Thank you.
Thanks,
Excellent
Prabhakar, for a
presentation. Excellent presentation by Prabhakar, especially the pathophysiology of corneal perforation. As in whole lot of postgraduates are there, and they are the first line person who attend trauma cases. So it is important to know the how one should suture, what depth, angle should be supported, and scleral wound. So it has been demonstrated very well. Thank you.
Thank you, Prabhakar. Just wanted to add something. With the advent of SICS and FACO, the classical teaching of suturing has been forgotten. And people now, in spite of suturing, they use glue. What is your take on such type of things?
For the corneal tear, sir? Yes. So it is like if your corneal tear is less than 3 millimeter, then you can still think of putting cyanoacrylate glue. However, if it is larger, then it's unlikely. And the disadvantage with the glue would be like the glue invites vessels. We want the cornea to be absolutely clear even post-operatively. So that is the main disadvantage. Anything foreign material onto the cornea is very likely to invite infections as well. So I would not go in favor of this. However, if there is a stellate in corneal injury, which is still leaking even after putting sutures, then I would prefer putting a cyanoacrylate glue there.
Okay, thank you.
Thank you, Prabhakar. Our next speaker is Dr. Amit Raj, who heads the AIMS Patna, and he's talking on management of traumatic cataract. And your time is 8 minutes.
Thank you, sir, for reminding the time, as we are running late and we have got the hall 15 minutes later. So I will try to cover it. So after dealing with cases of lid tear, canalicular laceration, and corneal perforation, now it is turn of traumatic cataract. So in a tertiary care center where we get lot of referral cases, primary cases of trauma where there is associated cataract, there may be multi injury, cornea, lens. So how to deal with it? So there may be different type of presentation, maybe isolated cataract, maybe post perforation. So again, in epidemiology, basically these are mostly occur in male, and it is associated with both blunt and penetrating trauma. Risk factor, mostly person who work outside, male gender, rural residents, these are more prone to traumatic cataract. Cataract can develop immediately, or it may later. So there may be damage to lens fiber and cataract formation, or there may be just initial capsular leak, and there is slow progression of cataract. So before taking this patient, one should take thorough history. One should take detailed history about the mode of injury, time of injury, and is there any associated ocular condition, or there may be any systemic disease that can affect the prognosis of the case. So in examination, one should check visual acuity, especially projection of rays is important. That will give clue if there is any posterior segment involvement or there or not. Similarly, pupillary reaction is very important. Intraocular pressure, if it is increased, it should be controlled with anti-inflammatory agent as well as anti-glaucoma agent. And one should look for sign for capsular damage and jonular dehiscence. These are very common. Dilated fundus examination, if possible, it should be done. And one should also rule out any associated ocular or orbital injury. Role of investigative modality is not overestimated, especially in hazy media. All these, especially we have access to B scan, there may not be access to OCT or intersegment OCT or UVM, but one should do B scan when media is hazy. In a study, it was found that UVM has better sensitivity and specificity compared to other investigative modality. It can present in different way, typical rosette, total cataract, maybe associated with opacity. So there is two school of thought, whether one should repair primarily or one should wait for control of inflammation. Both has different set of advantages. So before taking any patient of traumatic cataract, ideally there should be access of phaco machine. Conventional surgery should be avoided because you are not knowing whether there is vitreous leak or jonular damage. So these can be better dealt by phaco. There should be a standby of iris hook or pupillary expansion devices. There should be backup again 3-piece lens or PMM lens. Capsular tension rings or CTS should be there, and again there should be access of coaxial seizure microforceps. And most important is the vitreoretinal support. It should be there in cases there may be inadvertent nuclear drop. So intraoperatively, one should parameter should be low, bottle height should be low, and one should stain the entire capsule to rule out any tear. This is a case of a 22-year-old male. There was a history of blunt trauma, and there was 4 clock hour of subluxation superiorly. So all these cases should be stained, and in these cases rhexis should be initiated away from the jonular dehiscence. In this case, media was fairly clear, so that is why gentle hydrodissection was done, hydrodissection and hydrodelineation was done. At this stage, bag was lax, so CTR was implanted, and one should avoid implanting from main port. Ideally, it should be implanted from side port. In these cases, 3-piece IOL should be implanted. Second case, this was a case of 42-year-old male. There was thorough capsular tear, like Argentinian sign. There was history of blunt trauma. So again, capsule was stained. So after completion of cortical matter aspiration, in triamcinolone was injected to rule out any PC rupture or defect. So it was found that there was 3 clock hour of jonular dehiscence in this region, 4 to 7 o'clock. So as there was rupture of entire capsule, so CTR was not implanted, thinking that it can increase the it can go to the posterior capsule also. This was third case. This was a case of 22-year-old male, again history of blunt trauma 2 months back, and there was a traumatic cataract as well as there was a iododialysis, a small. So after clearing of posterior synapse, iris was hooked with the iris hook, and then capsule access was started, but the capsule was fibrous, so it was cut. So after aspiration of cortex, it was found that there was jonular dialysis in that region also, but it was highly fibrosed. So again CTR was implanted, and then 3-piece IOL was implanted. Then iododialysis was repaired. So what one should do, one should take thorough history, one should know the mode and time of injury, rule out associated ocular and orbital trauma. One should control the inflammation and IOP if it is increased, and must incorporate preoperative radiological investigation to rule out any foreign body or even PC rupture, and prerequisite should be there available. It should be available before surgery, and intraoperative phaco-parameters should be adjusted, and if there it should be there, VR support there should be there, and if it can't be taken, there should be no hesitation in referring to. So one should avoid ruling out any intraocular and intraorbital foreign body. If it is there, it should be taken care at the same time, and one should not miss associated jonular dialysis or PC rupture, because it can again jeopardize the final result. And I have seen basically one should avoid hydrotoxin, especially media AG, because chances of nucleus drop is very high, and patients should be told about the visual prognosis. There may be everything is right, but visual prognosis may not be good due to damage at the cellular level. Thank you very much.
Thanks, Amit. As usual, your presentation are full with academic stuffs. And our next speaker is the most proficient cataract surgeon, Dr. Subhash Prasad. He is talking on management of traumatic glaucoma. Oh, sorry. Here he is talking on traumatic glaucoma.
Thank you, Dr. Amit, for including me in this course. We all know that ocular injury can cause anything right from the conjunctiva, lead conjunctiva to the optic nerve or the orbit. And traumatic glaucoma occurring after any injury is very common. So it's a kind of secondary glaucoma that develops following blunt or a penetrating ocular trauma. And whenever any trauma occurs to the eye, there are several mechanisms which interplay to produce rise in intraocular pressure. So the types of ocular injury could be closed globe, that is blunt, or open globe with or without foreign body. It could be radiation, chemical injury, thermal, but I would confine myself to blunt and open globe injury. And the glaucoma can manifest anytime from early to late. So any case of trauma should always be followed for even for lifelong, just to see that patient is not developing rise in intraocular pressure. So coming to the traumatic glaucoma, which occurs secondary to blunt injury, we all know that whenever there is any injury to the eye, there is compression of the aqueous or the fluid and in the anteroposterior meridian followed by equatorial expansion, and there are 7 rings of tissues which are arranged circumferentially that gets actually injured. And so there is maybe injury to the sphincteric pupillary of the pupil iris base leading to iridodialysis, trabecular meshwork damage, anterior ciliary trauma causing angle recession, which is one of the most important or common finding after blunt injury, and you can say that this is telltale sign of blunt injury. And there could be a separation of the ciliary body muscle fiber from the scleral spur leading to cyclodialysis cleft. It can cause jugular dialysis, retinal dialysis. So all kind of injury can occur because of the expansion of, there is a compression, then decompression, then the adjustment and the oscillations of the globe. So glaucoma following blunt injury could be early because of trabecular disruptions, hypema, iritis, or choroidal hemorrhage, or late onset could be due to angle recession, ghost cell glaucoma, hemolytic, hemosiderotic, and lens subluxation or dislocation. So coming to the trabecular meshwork disruptions, most of the time it is detected on gonioscopy. There could be superficial tear or there could be full thickness tear. And this can lead to immediate and prolonged increase in intraocular pressure, which may eventually resolve. But once there is scarring of the trabecular meshwork, it can lead to late rise in intraocular pressure. Hypema is very important or very common finding which is seen after blunt injury or any kind of injury. So there is again the mechanism is the anteroposterior compression and then simultaneous equatorial expansion, which could lead to tearing of the blood vessels of the ciliary body and stromal iris. And if there is sudden rise in intraocular pressure because of the impact on the globe, it can lead to the damage to the fragile blood vessels of the iris ciliary body. That is also one of the causes of the hypema. And these can lead to obstruction of the outflow channels like RBC, fibrin, platelets. These all can block the trabecular meshwork and can lead to rise in intraocular pressure. This is more significantly seen in sickle cell anemia because of the abnormality in the RBC. So traumatic iritis which develops after trauma can also lead to rise in intraocular pressure because of the inflammatory debris getting collected in the trabecular meshwork and associated trabeculitis. Choroidal hemorrhage can occur due to sudden rise in intraocular pressure and then decompression. There can be, if it is too severe, it can lead to choroidal hemorrhage, and patients who are particularly on anticoagulation can develop this problem. And this leads to mass effect which causes forward displacement of the lens iris diaphragm leading to angle closure glaucoma. The late onset glaucoma pathophysiology is the angle recession, which is very important. There is tear between the longitudinal and circular layer of the ciliary muscles, which causes widening of the ciliary body band. So when you do the gonioscopy, you can see there is widening of the ciliary body band here. So that is very telltale sign. So you can detect any patient of this sign even years together, years after years. As per say, this does not lead to rise in intraocular pressure, but because of it denotes that there is severe injury, and this has led to scarring or trabecular meshwork, which is actually causing decrease in the outflow facility. So angle recession per se is not the cause of glaucoma, but the other associated changes. And it has been reported that if there is more than 270 degree, then 5% chance that patient will have glaucoma, but 360 degree angle recession, almost 1/4 of the patient will develop rise in intraocular pressure. Ghost cell glaucoma occurs following vitreous hemorrhage and generally seen 1 to 3 weeks after initial trauma because of the change in the shape of the RBC, which becomes spherical, rigid, and contains the hinged body. And this ghost cell reaches the anterior chamber through the disrupted anterior hyaloid phase after trauma and clogs the trabecular meshwork. Hemolytic glaucoma is rare. Hemocytic glaucoma, if there is any intraocular foreign body or because of the toxic effect of iron, it can cause TBM damage. So lens dislocation, subluxation is another very important or common finding seen after the blunt trauma, which can cause pupillary block. That is the most important cause of glaucoma in these patients. Or then can be secondary, there can be intermittent uveitis also, or occult phacolytic glaucoma also. So there is obstructions of all these. Sometimes vitreous coming to the anterior chamber can also produce this type of glaucoma. So traumatic glaucoma secondary to penetrating injury, generally once we see any patient of penetrating injury, the pressure is generally low, but it can later on lead to rise in intraocular pressure because of the shallowing of the anterior chamber with significant inflammation causing extensive anterior synechia leading to secondary angle closure glaucoma. And if there is posterior synechia because of inflammation, again it causes seclusio pupil and iris bombay leading to secondary angle closure glaucoma. And sometimes injury to the lens causes flocculent lens material coming to the anterior chamber that causes severe inflammation, and that can again lead. This is one of the which is seen maybe months or years after any penetrating injury lead formation of the iris cyst which causes glaucoma. So workup is whenever you see any patient of glaucoma, take thorough history, do the physical examinations just to rule out the patient has not suffered any other organ disease. Then visual acuity and everything, and gonioscopy in the acute stage should not be done. It's better to wait for some more time or some 1 week before we do that, and look for the jonular dehiscence. Indirect ophthalmoscopy must be done in all these patients. So gonioscopic signs of injury are like white gray membrane covering the angle, cyclodialysis collapse. Initially there is a low pressure here, but later on it can cause, if it heals, rise in intraocular pressure. So trabecular mesoflaps hinge can be seen at the scleral spur, and the torn iris process with blood in the angle can also be seen. And other investigation which can be done is the imaging by UBM to see the journal dehiscence, angle recession, cyclodialysis, clapped, anterior segment OCT, and perimetry, of course, to just see the magnitude of the damage. So management comes to the treatment of the underlying cause. Anti-glaucoma is the mainstay of treatment. What is most important is that don't use pilocarpine, or it's better not to use prostaglandin and inhibitor in this patient, prostaglandin analog in these patients. So better to use beta blocker and topical and systemic carbonic anhydrase. And if it doesn't respond, then ultimately we have to resort to surgical treatment. But one has to give enough time for the pressure to come down. Coming to the management of hypema, that is very important. If the hypema is such that the IOP is more than 50 millimeter of mercury for more than 5 days, or 35 millimeter more than 7 days, then it demands the removal or drainage of the hypema. If there is persistent or 8-wall hypema, then again you have to drain. Persistent hypema without sign of improvement, say around 22 weeks you have waited and it's not improving, even if it is not 100%, it should be drained out. And if there is a patient where there is active bleeding, one should do that. So this is a small video just to show in two different situations. Just doing anterior chamber wash is good enough to take out all the blood in many patients if it is early, but in some patient it can require actually use of cutter if the clot has formed in the anterior chamber. So these are two scenarios, but the most common is that most of the time it drains out, but you have to intervene before it stains the cornea, because once the cornea has endothelium has stained, then no matter whatever you do, the patient may not gain very good vision. So timely intervention is very important. Uh, so just to summarize, glaucoma can arise from any kind of trauma. It can manifest early to late, and to control the intraocular pressure and treat the underlying cause is very important. And associated ocular injuries must need attention and regular follow-up. I would say that lifelong follow-up the trauma cases are mandatory, just to see that the patient doesn't go blind because of this. Thank you very much.
Thank you, sir, for excellent presentation covering glaucoma cases. Although sir is all-rounder, sir can cover any cases. So any question from sir, if anybody wants to.
Don't give chance.
Okay, okay, thank you. So now I invite Dr. Abhishek. He will be speaking on management of posterior segment injury trauma. Dr. Abhishek is associate professor in AIOS Kalyani, and currently heading the vitreoretinal unit. And he is again very accomplished surgeon, and he had started. He was associated with us also, and he and Prabhakar were the two pillars. So with these words, I invite Vivek to speak.
Thank you, sir, for giving me this opportunity. So, posterior segment trauma, most of the posterior segment trauma which we see in our day-to-day life is mostly associated with blunt trauma. And the pathogenesis is either coup, counter coup, or antero-posterior compression. So, posterior segment trauma can manifest in various forms, and we will see each case one by one. So, coming to first case, the commotio retinae. So, it is a manifestation of blunt trauma where after an episode of a lathi stick injury or a cricket ball injury, there is white opacification of the retina. Here you can see the posterior pole, there is white opacification of the retina. And if you do an OCT, you will see the intraretinal hyperreflectivity and thickening of the retinal central macular thickness. And if you do if fluorescein angiography, it will hardly show any leak over the posterior pole. So commotio retinae, it is mainly because of the outer photoreceptor disruption, and generally there is no leakage on fundus fluorescein angiography. So patients have to be counseled that it is generally self-resolving, and if the damage is not that great, then it can slowly cause some vision gain. But one thing is that you have to do a peripheral fundus evaluation, especially the peripheral fundus, to look for any breaks, because blunt trauma are associated with peripheral breaks or dialysis. So choroidal rupture is another condition where there is a crescentic rupture of the choroid, just temporal to the macula or concentric to the disc. It can be focal, single, or multiple. It is generally temporal to the disc, generally in a concentric pattern, and it is generally because of tear of the choroid, Brooks membrane, and the RPE complex. Long-term follow-up is essential for these patients because of the breach of the RPE and the choroid. There can be development of choroidal neovascularization, which has to be treated with anti-VEGF injection. So if you see this OCT, this is the choroidal rupture along with subretinal hemorrhage, and if you follow this RP, you can see a focal break in the RP. So this can be a source of choroidal neovascularization later in life. Similar case, you can see a break in the RP over here, which can lead to choroidal neovascularization. So always we have to maintain a close follow-up of this patient for development of choroidal neovascularization. Again, you have to look in the periphery to rule out any retinal breaks or dialysis. And if you have a suspicion for choroidal neovascularization, then you can do an fluorescein angiography to look for leakage. So here you can see the outline of the choroidal neovascular membrane, which is leaking in the later phases, and in the late phase you see the obscuration of the underlying margin. Third most common entity is a traumatic macular hole. So this is again commonly seen after a blunt trauma, after a road traffic accident, patient presenting with a full thickness macular hole. Vision, depending upon the magnitude of injury, it can range from 612 to hand movement. And generally, we must rule out the element of traumatic optic neuropathy also, because this is very important. Because if we counsel the patient for surgery, then if a coincident, accompanying traumatic optic neuropathy is then the vision loss, the vision gain after surgery is very minimal. So always check for RAPD, look at the status of the disc, whether it is pink or whether it is pale. So we have to examine these things before counseling the patients and taking up the patients for surgery. And again look at the periphery, check the aura to rule out any retinal breaks or dialysis. Yes, and again, if the patient is presenting with traumatic retinal breaks or retinal dialysis after a blunt trauma, then that can lead to retinal detachment. In these cases, surely you have to first straight away refer the patient to a vitreoretinal surgeon for further management. So this can take in the form, the retinal detachment, it can have the various forms. So this is a retinal dialysis where retina is disinserted from the aura itself, or there can be a giant retinal tear, or there can be multiple horseshoe-shaped tears in the periphery. Sometimes you can see a brownish band which is straddling across the pupillary area. This is the vitreous base avulsion. So this signifies significant trauma, and again you have to meticulously examine throughout the retina, especially the periphery, to rule out any retinal dialysis or retinal breaks. Another manifestation can be traumatic dislocated lens. So lens can be partially subluxated, or it can dislocate totally into the vitreous and be lying over the retina. Again, you have to straight away, first of all, look for the coincidental other signs of injury, like increased intraocular pressure, subconjunctival hemorrhage. It can accompany occult rupture also. So before taking up the patient, you just inspect the overlying sclera, whether there is occult rupture or not. Look for vitreous in AC. A deep anterior chamber signifies a dislocated or subluxated lens. There could be a coexistent iris sphincter tear and retinal break. So in these cases, patients have to be referred to the vitreoretinal surgeon for taking up the patient for pars plana vitrectomy, lensectomy, and scleral fixated IOL. Another case is Terson syndrome, which is generally seen after a blunt trauma, especially in road traffic accident, where patients present with intraocular hemorrhage and also intracranial hemorrhage. So this can manifest either in the form of subarachnoid or subdural hemorrhage. So this is one case which we saw. One of the nursing staff, he presented after a road traffic accident. He presented with a subhyaloid hemorrhage over the macula. So on the CT scan showed a subdural hematoma. So we took up the patient and we did, this is the OCT. There is a detached overlying posterior hyaloid and a subhyaloid hemorrhage. So we did a YAG hyalotomy, which drained out this blood, and finally this blood was cleared out. So whenever a patient is presenting with subhyaloid hemorrhage after a road traffic accident or a blunt trauma, always we have to take a history whether he was unconscious or whether there was a lucid interval, and if there are suspicion, then do get a CT scan done, because this can reveal underlying subdural hematoma, which can be lead to a neurosurgical intervention also. So sometimes, very rarely do we come across non-occidental trauma in a form of in infants in a form of shaken baby syndrome, and this is generally seen in first-time parents, mostly male, who are either suffering from depression, where they repeatedly hurt their infants, their child, and there can be a triad of subdural hematoma, subarachnoid hemorrhage, and retinal hemorrhage. So this can manifest in the form of hemorrhages in all the retinal, either in the preretinal hemorrhage or in the intraretinal or subretinal hemorrhage. Hemorrhages of varying ages. Some will be fresh, some will be old, which can accompany an intracerebral hemorrhage, and it is either because of repeated abuse of the infants. And this can also accompany other external signs also accompanied with ledecymosis, conjunctival tear, hyphema, or corneal laceration. So basically here the problem is with the parents rather than with the children. So first of all, counseling to the parents, and again attending the subsequent injuries among the infants, which we have to do. So, and now in this case of war, sometimes we come across a traumatic chorioretinal rupture, which is secondary to a high-speed missile injury. So actually, this is a case of coup injury where a missile grazes a part of the temporal part of the eyeball, and all the shear stress and all the shock waves are suffered, causes damage of the temporal part of the retina. So here we see. So here you can see here the temporal part of the retina, it is totally sheared out, leading to loss of the retina and choroid, and lying bare of the sclera, which is totally bare. So here also just we have to plan, do a meticulous follow-up for development of for management of any complications which can happen in later in life, like neovascularization or retinal detachment. So one case which I would like to share, which is generally seen after a road traffic accident, especially after fracture of long bones, or in case of acute pancreatitis, is a case of puncture retinopathy, where patients can present with multiple retinal opacification throughout the fundus. So this is basically because of either long bone fracture and chest compression injuries, or it can be seen in area or amniotic fluid embolization.
Dr. Abhishek, please summarize. We are running out of time.
So to conclude, all general ophthalmologists, they should be familiar with the posterior segment manifestation of trauma, because timely evaluation and thorough evaluation is very critical, and they should be aware of the potential and late complications which can happen in each case. So thank you, sir.
Thanks, Dr. Abhishek, for beautifully covering all the cases and especially highlighting do's and don'ts, especially for general ophthalmologist. Now I invite Dr. Vivek, who will be speaking on management of orbital trauma. Dr. Vivek will be speaking on behalf of Dr. Gyan Bhaskar sir, who could not make up due to some urgent issue.
Good afternoon, everyone. I am speaking on orbital trauma. I will just go through a basic format what to do in cases of orbital trauma. Generally, we encounter orbital trauma in cases of road traffic accidents. So we can have following things in the road traffic accidents, like orbital fractures can be happening, hemorrhage, foreign body, emphysema, and luxation. We will dealing with one by one, although each can associated with each other also. So first of the thing, if any person present with a trauma, then first we have to divide the injured eye into two parts, whether it is the trauma of lid, whether it is intraocular trauma or extraorbital trauma is there. Orbital fractures, the most common we found in orbital trauma, where it can be associated with orbital skeleton only, which can be pure or impure blowout fracture. Whereas sometimes the severe gravity of injury is so high that the fracture of orbit is associated with maxillary fracture, NOE fractures or zygomatic fractures. So we have to divide initially evaluate all these things in cases of orbital fractures. So the most common fracture which we encounter is the blowout fracture, which is the most common injury in the eye, which can involve all the valves, but mostly the floor and middle wall is involved in most of the cases. It can be a pure fracture or an impure fracture. The pure fracture meaning thereby it is associated with orbital fracture, but orbital rim is intact. Whereas impure fracture, where wall of the orbit is fractured associated with orbital rim, which we term as an impure fracture. So effect of orbital fracture, we can get a herniation of orbital contact, or sometimes entrapment of inferior rectus is most common in inferior wall fracture, but other muscle is also get entrapped, where fat entrapment is there. There may be damage of intraorbital nerve, or maybe there is dissection of orbital nerve or optic nerve also. So what are the clinical features they present? They can be present as diplopia, intraorbital numbness, periocular ecchymosis, or in ophthalmos or hypoglossa, or orbital emphysema is also observed in some cases. So what is a trapdoor? There is one interesting case, that is trapdoor fracture. Generally it occurs in children and young adults where the bone is not calcified, where they present to us that patient is presented, there is no sign and symptom in anterior segment, eye will be completely white, his vision will be normal, but when you examine carefully about the extraocular movement, then we find that there is a restriction of extraocular movement, and then we have to advise in such cases the MRI. Then we found that there is a teardrop sign is there. There is small content or inferior rectus muscle is entrapped in inferior floor fracture because of the wall is not very calcified, so that the fracture goes, and at the fracture time the rectus get entrapped in that place, and then the bone goes back to them. So there will be no anterior sign, no other signs of any trapdoor fracture or involvement, but there is only one thing where we find there is a restriction of movement, and this case has to be very much examined carefully. Whereas in investigation in any fractures, there previously we used to do plain X-rays. Then computerized tomography is the diagnostic of choice in acute cases. But the ideally we should have to do a magnetic resonance imaging with computerized tomographic cut, so that soft tissue injury will also be evaluated clearly with that of the bone fracture. Initial treatment of that fracture is use of nasal decongestant, broad spectrum antibiotics, and oral steroid to prevent fibrosis. Whereas in main surgical management, we have to wait and watch if there is no significant in ophthalmos, there is no marked hypoglossus or no entrapped muscle or tissue, and fracture where the orbital content is not very much prolapsed. So we can, in such cases, there is lack of diplopia. Such cases we can wait and watch. We cannot go immediately for the surgical management. We can observe the patient. If any signs develop, then we can go for any management, and we can manage to improve the local antibiotics and short course of oral steroid to counter the inflammation and infection. So there are different guidelines based on where we have to innovate. The guideline is for acute intervention. If the patient present with diplopia with positive forced duction test, meaning thereby any muscle is getting entrapped in there, there is in ophthalmos with 2 mm, that is cosmetically unacceptable, but this case can be encountered after 6 months, so that there may be every other things get healed. Large fractures which causes at least half of the orbital floor fracture, then we have to do a repair in such cases. So surgical management, so we have immediate intervention where diplopia with shows entrapped muscle, or non-resolving oculocardiac reflex, where we have to intervene immediately. Otherwise, we can wait for few days to heal other parameters. Patient should be stabilized properly. After that, we can do a surgical management. It can be delayed in cases of blood fracture, which can plan surgery for 7 to 14 days after the trauma, or waiting time is allowed so that spontaneous improvement of edema will be there, resolution of swelling which we have faced difficult during the dissection, or then primary planning of the what should be the best surgical outcome for such cases. So surgical management, it can go from incision where previously we go through the skin incision, but mostly our incision is concise to subciliary or subconjunctival incision. Implants which we can use, different implants are available, that we can use autologous implants like clavarium, iliac crest or ribs, but most commonly we are using titanium mesh, which can be a 3D modified or 3D implants, or some peak implants can be used for implanting the floor fracture depending upon the size and area of involvement. Newer implants like composite polyethylene implants, titanium mesh or polydixon or glycolic acid implants are in use also. So these are the for orbital fractures. In orbital hemorrhage, it can be localized to subperiosteal or extracornal or intracolon within the orbital soft tissue or within the belly of extraocular muscle. Patient will present with pain, diplopia, decreased vision, ecchymosis, edema, elevated intraocular pressure. Maybe choroidal folds will be there. Blood luxation can be there because of this hemorrhage. It is a case of acute management if it causes optic nerve compression. So medical therapy, we can give you intravitreal mannitol, acetazolamide, steroid or tropical beta blockers to tackle this pressure effect of the to counter the pressure effect in the orbit, because orbit is a closed box. We can do a lateral cantholysis or canthotomy as an emergency procedure to relieve the pressure, which is a very simple procedure. And after that, most of the cases in RTA, which is a infected fracture, there is a metallic or non-metallic foreign body we can encounter a lot of the time. So we have to judge about, take the proper history, whether it may be there, the foreign body may be, when we suspect there is a foreign body, it can be metallic or non-metallic. So if we suspect a metallic foreign body, then we have to be very careful in advising magnetic resonance imaging. In that case, a CT scan is the investigation of choice. Otherwise, if patient give history that there may be a non-metallic organic body, so we have to go for the MRI scan to find any foreign body and deal simultaneously. So on managing, there is a treatment of choice. We have to give treatment prophylaxis. There is culture of the infected particles should be done to get the choice of antibiotic. Organic foreign body like wood and vegetables has to be removed, which can be easily accessible for anterior orbitotomy, whereas foreign body related complications like in the optic nerve compression, infection and extraocular muscle movement restriction should be taken care of in such cases. We often encounter a few cases of orbital emphysema. Yes, I will sum up here. Emphysema, where patient complains after sneezing, they get some blurring of vision, and mostly the MRI will show there will be some air pockets in the orbit. Such cases are generally countered with management. Conservative management is done, and most of the cases resolve in 2 to 3 weeks of conservative treatment. Often, sometimes we get a globe luxation also, which causes severe anxiety to patient, and and it is an emergency process where we can easily reposition the globe, which using the C maneuver, which easily we can pull up the lid with the help of any forceps, or if it is not available, we can even use a safety pin as they have demonstrated, and pull up the upper lid and pressurize and put back the globe back into the orbit. So it can be managed like this, and finally temporary tasography can be done. Thank you.
For presenting very well and accepting our request to present at last moment. Thank you. My apology to OSW team. We have got the hall 15 minutes late, so thank you for bearing with us, and thanks to all the presenters, senior person, audience for bearing with us. Now I request all the presenters to come forward for a group photograph. Thank you.